Is Nahumicha Wafula, but in studio I have Dr. Elias Meli from the National Cancer Institute of Kenya. We also have Dr. Primus Ocheng, who is the Program Director at the University of Nairobi Oncology Training. I have one Dr. Naftali Busakara, who is from KESHO. KESHO means Kenya Society of Hematology and Oncology, and of course Governor Muthomi Njoki, the Governor of Tharaka Nithi County, and also the Chairperson of the Health Committee at the Council of Governors. And let's begin with you, Dr. Meli, because we've had so much, especially talking about the diagnosis process. So the various experts are talking about the index of suspicion. Maybe you can help us understand, in the country, what is the status of diagnostic capacity, and what are these facilities that can be in a position to do this, and what is the sort of referral mechanism that we have?
Well, thank you, Sam and Christine, for having us tonight. We are glad that for the first time in our country, we are having such a national conversation on an issue which is really key, and it's causing a huge, burden in our community, socially, economically, spiritually, and giving it this immense attention will definitely go a long way to improve, diagnosis of cancer if we cannot prevent. You've asked me a direct question on cancer diagnosis in this country. But before I talk about that, allow me to just mention that the National Cancer Institute of Kenya has this responsibility to coordinate all cancer activities in the country. And it was established because of the huge burden of cancer. We know globally the burden of cancer is quite high, and regionally and nationally, and we can see this even in our communities. And every family is affected. We are all affected. And our country has put in very clear strategies now to address this challenge, looking at it through the entire continuum of care, from prevention to early detection, diagnosis, and treatment. If we look at diagnosis, the question you've asked me, Sam, over the last 10 years, after devolution, there is a lot that has improved in terms of diagnosis in generally for conditions across the country, without talking about cancer, because you present when it is not cancer. You present to the hospital when we are having symptoms that we are not specifically sure that this is cancer. But in the process of the doctors, talking to you, taking that history, examination, all that leads towards diagnosis of cancer before we consider now imaging, which would lead us to know there's a growth, because cancer, predominantly, cancer would begin from mutation, an error in DNA, which is pretty much our genetic makeup.
Right.
And then it grows, it multiplies uncontrollably, excessively, and it has capacity to spread from one point to another. So when it multiplies excessively, then this is when we now see a growth. And this is when symptoms would present, probably pain, probably obstruction of a lumen, and someone will present. That is when the doctor now will ask for imaging. And when you ask for a scan, you are likely to now pick there is a growth. So in terms of diagnosis, we have two modalities. You diagnose using what we call pathology, or you diagnose using what we call radiology and imaging. Pathology is where once we have scanned and we found out predominantly most solid tumors. We also have blood cancers that you will not see a growth, but most solid tumors, if you are going to scan and you find there's a growth in the abdomen, in the brain, on the breast, or in your cervix, then that is using X-rays, ultrasounds, CT scans, MRIs, and now PET scans. In our country, the capacity has increased immensely over the last 10 years. And almost every county, through the MES program, almost every county now has increased capacity in diagnosis. We almost have a CT scan in every county. Lately, through our strategies to improve cancer care in our country, we've been doing every county cancer action plan. And we have noticed most counties have CT scans capacity, because that's the basis of diagnosis on radiology and imaging. We have a challenge, though, in pathology. Where we have very few doctors in that area, and we have very limited equipment and infrastructure. But certainly, there is a lot of improvement.
Okay, and we'll get to that question of the index of suspicion because it may speak to capacity, especially of the human resource, but also to inform you that this broadcast is in partnership with the National Cancer Institute of Kenya. NCI is an agency under the Ministry of Health that coordinates all cancer activities from prevention, early detection, diagnosis, and treatment of cancer across all continuum of care through quality service delivery, training, and research towards reduction of the burden of cancer in Kenya. Christine?
Waziri wa Afya Bi Susan Nakhumicha ndio wamejiunga nasi katika mazungumzo haya. Karibu sana waziri. Hapa mjadala unaendelea ni kuhusu masuala ya kansa, matibabu, gharama ya matibabu, aina mbalimbali za kansa. Tuna wataalamu katika studio zetu hapa, tuna wale ambao wameugua kansa, wale ambao wamepona. Kwa hiyo tungependa kufahamu pia kutoka kwako, manake utafiti unaonyesha kwamba kati ya 70% na 80% ya wale ambao wanagunduliwa wana saratani wanagunduliwa wakiwa wamechelewa sana, wakiwa wamefika stage 4, stage 3 na stage 4, ambazo wataalamu wanasema kwamba kidogo inakuwa ni changamoto. Kwa hiyo tungependa kufahamu kutoka kwako kama ambaye anasimamia hii idara ya afya nchini kwamba je, kama mipango Wizara ya Afya na serikali kwa jumla, ni mipango ipi ambayo mnaweka kuhakikisha kwamba utafiti ambao unafanywa, tuna mashine, wataalamu wa kutosha kuweza kutambua mapema ikiwa mtu ana kansa, manake hii kungoja sana inaleta changamoto.
Asante sana Christine, nashukuru idara hii ya Citizen kwa kunialika nije niongee na Wakenya na pia kwa kuangazia mambo ya saratani. Na nashukuru kwa sababu naona umeleta mtaalamu wangu, my senior advisor, Dr. Meli, ambaye ndiye Chief Executive Officer wa National Cancer Institute. Na hii ndio mbinu moja yao ya kuweza kuwajulisha Wakenya na pia watu wengine kwa ujumla juu ya hali ya ugonjwa wa saratani. Na vile umesema, na niliingia daktari pia akiongea, ugonjwa wa saratani ili tukaweze kuangamiza kwenye nchi ni kuhakikisha ya kwamba tunaweza ugundua mapema, kufanya screening ya mapema ili ukaweza kugundulika. Wao umesema vilivyo ya kwamba wagonjwa wengi wanajulikana wakiwa wako kwenye stage 4. Hiyo inamaanisha matibabu inakuwa ni ya bei ya juu, na pia ugonjwa unapatikana ukiwa umeshaenea mahali pengi mwilini. Unajua saratani ni ugonjwa ambao una multiply haraka. So kama serikali kuu na wizara, umeona tumezindua juzi mpangilio na tumesema ya kwamba sasa sisi kama wizara tunataka sasa kuhakikisha ya kwamba tuna focus mambo ya primary health care. Ya kwamba tuwe sasa muda mwingi ambao umepita tumekuwa tukishughulikia mambo ya matibabu ya kihali ya juu, na ili hali ugonjwa mwingi tunaweza kuzuia tuki concentrate na primary health care. So kama wizara sasa tumefocus, na ndio kwa maana tuko na wale tunaita community health promoters. Unajua tuko na 1,100 nchi mzima. Tumewapatia vifaa ya kuweza kuenda kwenye households, kwenye community, manyumbani. Kila community health promoter mmoja anashughulikia watu 100. Mbona tumefanya hivyo? Sisi tunataka kuhakikisha ya kwamba tunazuia ugonjwa kabla ufanyike, na pia tunaelimisha watu mambo ya hali ya afya. So katika hiyo hali au community health promoters wanafaa kuwa kukuelimisha, lakini pia wakisha kukuangalia, kuongea na wewe, uwe uko na muda wa kuongea nao kuhusu hali yako wewe kwa ujumla. Wakipata ya kwamba uko na ugonjwa, basi wanakurefer kwenye mahali ambapo unaweza pata usaidizi ama unaweza pata matibabu. So katika hii hali ya kungangana na hii ugonjwa wa saratani, nimesema the most important thing is screening. So wale community health promoters, najua maswali ni kwamba je wataweza kufanya screening, but I want to encourage Kenyans ya kwamba community health promoter, huyu mhudumu wa afya wa nyanjani, akija kwenye nyumba yao, talk about your health in total. Ongea mambo yako ya kiafya kwa ujumla. Unajisikia vipi? Je, unaona uko sawa? Ni nini umeona ni kama inaweza kuwa kuna kasoro? Unajua Wakenya ni watu ambao ni wavumilivu sana. Mtu anaweza ona hata ako na uvimbe lakini anaona sina maumivu mengi, haendi kwa matibabu. Anangojea mpaka ile siku yenye ugonjwa itakuwa imemziba kabisa, ako na maumivu makali, ndipo anaenda. Sasa hawa community health promoters wa Kenya wakaweze kuwa na mazungumzo nao. Akija kwenye nyumba yako, mueleze hali yako iko vipi. Wewe kama ni mume, mke wako wako vipi, watoto wako vipi? Je, kuna kitu unatazama katika mmoja wa your family members ambayo inaonekana kama si ya kawaida? Je, labda mtoto amekuwa akikohoa muda mrefu ambao sio wa kawaida? Ama labda we ni mama ukiosha mtoto unaona kuna uvimbe ambao unaona si wa kawaida, labda hakuna maumivu lakini kuna jambo ambalo si la kawaida. So tunataka kuhakikisha ya kwamba hawa tunawatumia kuanzia chini kabisa kwenye household, afya nyumbani, waweze kuangalia ni vipi basi tutaweza kuhakikisha ya kwamba Wakenya wengi tumezuia ugonjwa, tumewaelimisha juu ya ugonjwa, na wale ambao tunapata wako na shida yote wamekuwa referred mahali pale wanaweza pata matibabu.
And Waziri will get to more interventions, but let's hear from the counties because, Governor, you lead a county and devolution has been on for more than 10 years now. Health is basically quite devolved apart from the policy direction that may come from the ministry. But what would you say is the true picture on the ground? You can start with your county specifically, but also the bigger picture across the counties when it comes to the diagnostic capacity. Yes, we hear of screening, that you want that the health workers are as suspicious as possible, but what is the capacity that you'd speak of?
Thank you very much, and allow me actually not to start with the counties, allow me to start with myself. Because I would be like to speak to the Kenyans that when we talk about cancer, it's a national conversation that affects anybody in this country. It is not for the poor, it's not for the rich, it's not for those who are ignorant. I say I started myself because I always give this story. My father was a nurse, and even as he was treating other people, he developed a pimple on the neck. And I remember him saying, when I was a small boy, that I do not want to go to hospital in Nairobi because I don't want to be found with cancer. You know, that kind of attitude. And eventually, that pimple developed to something else. And to cut the long story short, my father eventually got cancer that affected his ears and I think TNC. We spent a lot of money here on, and at that time, there was... we did not have advancement in chemotherapy. Mostly we used radiotherapy. And eventually we lost him. And I remember saying to myself, never again. Because had we taken our dad to hospital in good time, probably early detection would have saved him. I said never again. But 28 years later, when my mother was diagnosed with a stomach problem that we took to several specialists in stomach. And eventually she was diagnosed with stage 4 of pancreatic cancer, which the doctor tells me is usually very hidden. It is the one that actually kills Steve Jobs of Apple, and with all the money that he had. It means that the attitude, even out there, because I've had one patient there saying that there's usually stigma among our patients. When somebody is told you have cancer in Kenya today, first thing that comes to their mind that there's a possibility that I'll go. Why is this the case? As I talk about the counties, if you look at the global picture of cancer, the whole world, 70% that is killing people is happening in middle-income countries and low-income countries. Do we have bodies that are different from the first world countries? Of course not. There must be something that they're doing that is different from what we're doing that is making them not see cancer as a threat, because almost 95% of their patients recover. And that is what we need to address. And it basically boils down to the issue of the cost of almost every stage of cancer, be it diagnosis, be it screening, all the way to the treatment in this country. Right. We must address the issue of the cost, access to this treatment, and even their diagnosis. In the counties at the moment, we have only 10 cancer centers in the whole of Kenya, in actually 10 counties at the moment. We were in the process, I think, of increasing with another 4. I'm not very sure that it's been done. But that tells you that not every county can be able to do diagnosis, screening, to the level that they go to treatment without having to move to a neighboring county
So
also.
cancer centers are for basically treatment?
They are basically for treatment.
But what is the capacity for diagnostics?
The capacity for diagnosis, from the level 3, it is possible to do simple diagnosis like pap smear. They are also able to do VIA. We are able to do mammogram in level 4. We are able to do also, we are able to use CT scan probably for those who have radiologists. However, there are counties that do not have the personnel to be able to...
Can you be specific? Tell me the story of your county.
Yes.
Are you able to screen and tell people this is what you're suffering from? Or it has to be somewhere else? Well,
I have to be factual. Up to some extent, we do clearing and forwarding. In terms of, we do not have the capacity because our county does not have MRI. If we need something that needs to have a scan with MRI, we have to send to Nairobi. CT scan is possible. But again, it is not every radiographer and radiologist who is able to detect cancer. Okay. We need an oncologist radiologist.
So Nairobi is your nearest?
Nairobi is our nearest. Okay. And just to make it very clear, in the counties, when you look at the number of oncologists in the whole country, in the issue of HRH, the number of nurses who have done radiography, you might find that in a county, you might find only 1 or maybe 2. You may find there's no such doctor in such a county. And therefore, and it's not because counties don't want to employ. You advertise and you don't get anything.
Okay.
Last time I checked with yeah.
We'll get to more details about that.
Yes.
Christine?
Dr. Naftali Busahala, wewe unatoka katika shirika la Kesho ambalo linafanya utafiti juu ya saratani na magonjwa ya damu. Katika hiyo sekta ama nyanja hiyo ya utafiti, je, ni mipango ipi ambayo mnafanya kuhakikisha kwamba saratani inaweza kugunduliwa mapema? Manake kilicho wazi hapa ni kwamba kugundua saratani imekuwa ni changamoto.
Asante sana Christine na Sam. Tumefurahi kuwa hapa na asante kwa wote ambao wamehusika kuhakikisha kwamba huu mpango unaendelea. Katika Kenya Society of Hematology and Oncology, yani Kesho, dhamira yetu ni 2. Dhamira ya kwanza ni elimu, education for members, kuhakikisha kwamba tuko na qualified manpower, not just at the level ya specialization, lakini pia subspecialization. Dhamira ya pili kwetu ni research. Na kwa hii dhamira tuko na ile inaitwa research committee ambayo inahakikisha ya kwamba tunafanya ile mentorship. Hiyo ndio kitu ya kwanza na hiyo ndio kitu muhimu sana. Kuhakikisha ya kwamba wale ambao wote wanataka kufanya utafiti katika hii nyanja ya kansa wanasaidiwa kuandika zile proposals zao. Na wanasaidiwa pia kuonyeshwa pale funding inapatikana. Na pia wanasaidiwa kufanya ile tunaita publication. Kuhakikisha kwamba zile articles wameweza kuziweka pahali ambapo watu wanaweza kusoma. Kitu ya pili ambacho tunaangazia sana ni awareness. Utafiti kuhusu awareness. Tunataka ya kwamba watu wakuwe their own champions about cancer, so that waelewe mili yao, wajue ya kwamba shida ikitokea hapa ndio tutafanya. So tuna utafiti kuangalia specialists, na kuna utafiti pia kuangalia the general population. Yeah, so hivyo ndio tunafanya.
All right.
Katika Kesho.
All right, Dr. Primas, talk to me about, because you're in the training area, and obviously the health workers are from different cadres and different levels will be working at different facilities. Like he says, there are challenges when they want to hire, they cannot find a lot of talent to get their employees from. But what are the challenges, and what would you say is the training output, especially for the diagnostics level?
So thanks so much, Sam and Christine, and this is a very great opportunity for us to tell Kenyans what the government is currently involved to actually improve cancer care. So when you get sick, you need a diagnosis. And you need a diagnosis, you need a doctor. We have had many doctors in this country. And remember, before, our diseases were malaria, TB, and HIV. And government had put so much money, and many doctors were trained, and we had enough doctors. Then suddenly cancer came. And remember, before we thought cancer was a disease of the Europe. So in the last 10 years, the government has now tried now to shift its paradigm in disease management and move from malaria, TB, HIV now to the new disease, cancer, and of course also the other non-communicable disease. So this caught many African countries, and not Kenya alone, that suddenly we didn't have doctors to be able to treat cancer, to treat patients, to diagnose them. We didn't even have centers. For a long time, it was just Kenyatta alone. And so the University of Nairobi, where I come from, there has been a lot of work to actually help in diagnosing cancer. So cancer diagnosis is very complex. It's not like any other disease. When you have, say, malaria, the doctor takes blood from you, check it under a microscope, look at it, and get it. In cancer, the diagnosis starts with the doctor who knows about cancer. As everybody has said, cancer comes like any other disease. Like Waziri's, it was a pimple. So you must have a doctor who knows the pimple there can actually be a cancer. So you must train that doctor, and the doctor must know that it is something suspicious that he needs to do more about. Then the next important thing is that you must prove that you have a cancer cell. And that means the little lump or the little growth or whatever you get must be checked under a microscope and confirmed. So these are called the pathologists. And the pathologists do so many checks that the pathologists who actually just check the cells and say this cell is abnormal. But you need a pathologist who can tell you that this cell is not only abnormal, but it is cancerous. Now, it is always very difficult to tell what is normal from abnormal, because cancer cells sometimes are very close to the normal cells, or they may be just starting. And so you need it to be very, very different. So you need to stay, and that is one of the areas where we actually are struggling, because we don't have enough pathologists.
Right. And
that's why, as Waziri was saying, specimens are coming from all over the country, still have to be checked in Nairobi, because we have probably about 90 pathologists in the country to do the diagnosis. Well, we also need many other pathologists, because we need only currently the government is training pathologists, but some have to help do the postmortem, some have to help do the laboratory work, some have to help in actually diagnosing other diseases, and then you have to train them. We currently are training pathologists in this country in about 3-4 universities. But for a long time, many doctors have been attracted also to other areas of specialization.
Right.
You know, all of us, we want to go into an area where we earn more. So people would like to become neurosurgeons, because we all believe neurosurgeons are very tough people. They can do a better work than a pathologist. So more doctors have been attracted to certain specialties and not like pathology. So that also explains why.
Okay.
Again, oncology, where now once the diagnosis is made, you need oncology to treat and also help. We also lack oncology, because doctors actually at first were not so attracted to oncology, because the oncologists probably were people taking care of cancer. And one time we thought cancer was a disease that if you get it, you die. And no doctor wants to spend his time taking care of those who are going to be lost. They want to take care of those who are going to, like hypertension that we keep seeing. Yes.
And later on we'll speak to Waziri to tell us about the policy interventions, as at least to improve the numbers of people that can be in a position to do that. But Dr. Meli, talk to us about, because of all these challenges of diagnostics and the capacity that we are talking about, what is the bigger picture, and what do you think would be a solution to ensure that even as we encourage, because Waziri says that there is the community health promoters, what is the bigger picture so that people don't have to travel from Tharaka Nithi to Nairobi for certain processes of this diagnosis?
Well, thank you, Sam. I think if there is anything we should celebrate in this country, is devolution. Because healthcare being a devolved function, then devolving in our constitution healthcare, if we really have to address this issue to make sure that we reduce, the burden of patients being referred to urban centers, predominantly Nairobi and Eldoret, where there is more capacity in cancer care, as the other upcoming, urban Nakuru, Mombasa as well. So the best thing that we can do in this country is to make sure we build capacity in our counties. And if you look at resources that goes into building capacity in our counties, it's still quite limited. I'd mentioned earlier on that as of today, we have assisted our counties, 20 of them, to develop each county-specific cancer action plan. And one of the thematic areas that we're looking at is cancer diagnosis. It is quite unfortunate that there are some counties that would not, have any investment in that area. And coming in with our technical assistance as a role of the National Cancer Institute of Kenya, we are showing them that, yes, you can, and we can work together with the assistance of the national government and working with the county government. We can actually commit resources and we can have a plan. We have a national sector cancer strategy, and it has highlighted how we would want from the national, and I know later on we may have to go through that policy document because it's quite important. But if we're going to improve capacity in our counties and find ways of making sure we invest in infrastructure in our counties to make sure we have the requisite buildings, we have the requisite equipment. We are also looking at human resource, very important, human resource in health. It is probably one of the most costly, intervention that every county needs. And not only training, we also need to find strategies on how we are going to retain them. Because, again, most doctors who are being trained by rural counties, a lot of them ultimately, move to urbanized counties, Nairobi, Kiambu and Kajiado around Nairobi, or Uasin Gishu County, Nandi, Elgeyo Marakwet, where they are within, an urbanized area. So we need to find ways of motivating them to remain in the rural counties. And we are discussing with them. And I'm happy because having this discussion at this national level, I am very sure after this, there are going to be clear strategies on how to support them. And we are not only looking at HRH as well, we are looking at commodities that they need for diagnosis. Okay. When we've been discussing with counties, they have a lot of challenges on reagents. These are quite expensive. If you look at screening for cervical cancer, for instance, you are doing HPV, test DNA or RNA. If we were to speak on the terminologies that we need to use in diagnosis, most counties cannot afford these reagents. And they're important in early detection of HPV, that is one, So we really have to invest in human resource, infrastructure, equipment, and commodities.
Who can make those detections? Who can detect that? Which facilities?
Currently.
You said many counties can't.
Many counties can't, especially histopathology is quite a challenge. If you look at the counties that have capacity, I can mention a few. Of course, Nairobi County, Uasin Gishu County, Mombasa County. We have Kakamega County. We have Kisumu County. We have Kisii County.
Okay.
And
Nakuru.
And Nakuru County.
Okay.
We also have a lot of support from
kiwango cha level 6.
Exactly. Most diagnosis of cancer is made at level 6 hospital, or level 5 at least, because we have level 6 hospitals. We only have KUTTRH, Moi Teaching, Kenyatta. Those ones are fine. Those ones even have training programs. And the level 5 that we have mainly, it's Mombasa, Nakuru, Jaramogi Oginga Odinga, and Kisii and Kakamega.
Asante sana. Sasa hivi tunakwenda katika hospitali ya Chuo Kikuu cha Kenyatta. Hii ni hospitali ya rufaa na mafunzo. Mwenzetu Lilian Muli yuko pale na pia na maelezo zaidi.